Somewhere in this state right now, there is a patient who, because of language issues or culture issues, is not getting the quality of health care that he or she needs. We maintain a real sense of urgency about this issue.
California has one of the most diverse populations in the United States in terms of ethnicity, in terms of race, in terms of country of origin.
There are so many people from so many countries, including me.
It's clear that diversity is a gift for the state of California, but it presents a wide variety of challenges.
When people of different ethnic groups have similar insurance to what Caucasian patients might have, they still tend to get a different level of service.
Infant mortality rates in our county show us that we do worse than maybe a third world country. It tells us we need to change the way we're doing things.
We think that a lot of that disparity is caused by the cultural or language differences that exist.
Disparities in outcomes in healthcare based upon race or ethnicity is actually, when we get down to the fundamentals, it actually is a violation of someone's civil rights.
Everybody should have access to equal care, regardless of their ability to speak the language or whether they can pay for the service.
The California Endowment engaged in conversation with leaders from the medical community about how we could create a medical leadership council that could address the issues of cultural proficiency and language access.
It is my pleasure to welcome you to today's meeting of the Medical Leadership Council.
Thinking back 7 years ago, these issues were really not on a lot of people's radar screens.
Language access didn't mean too much to me at that point.
Language access means to be able to understand other people who speak a different language.
Since its inception, the Medical Leadership Council has really focused on getting high-quality, live, trained interpreters and excellent translated documents that we can give in written form in the threshold languages to the patients who need it.
You have 30, 40, 50 different languages.
We had 100 dialects.
Armenian, Bosnian, Spanish, of course.
French,
Cambodian,
Portuguese,
Chinese, Mandarin, Cantonese, all these different kinds of languages and dialects.
About 40% of Californians report speaking a language other than English at home, and of those, half report being limited English speaking, so at least according to the census, saying that they speak English less than very well.
You may be able to reduce your medication over time.
You can't provide quality care and you can't connect with a patient unless you can communicate with that patient about his or her needs in a comfortable way.
I don't understand what are you referring to.
Sometimes if you can't communicate, it's like having a comatose patient. You can't get any history, you can't determine what's important, what are the important symptoms from the patient standpoint. And that really is the foundation for, the diagnosis.
A patient I had only spoke French, but I insisted that we be able to communicate with him because he was a little agitated. His arms were restrained or tied to the side rails of the gurney. And after talking with the patient through the phone interpreter, we were able to have him be calm enough he no longer needed to be tied up while waiting to go into surgery.
When we realized that well over 2,000 of our bilingual employees were providing interpreter services, we said, where is the competency level of those employees to do that? And that was a key point that we got from the Medical Leadership Council. It's one thing to provide a service, but if you're not providing a quality service, you're really doing a disservice to the patient.
Language is one aspect of it, but more than that, I think actually cultural competency is a lot more important than just a language access.
Cultural proficiency is care that is concordant with the values and lives of the patients we're trying to help.
Each culture has its own things rooted for thousands of years.
To have the sensitivity and awareness that this patient may have some special needs because of his or her ethnicity is a step in the right direction.
For example, a patient may believe that there are certain homegrown remedies that they've heard about all their lives that they would try
and it's beneficial. And you should accept that, especially if it has some scientific basis. And even if it doesn't, you want the patient to tell you about it.
You really have to learn that the grief process is really different in different culture. There was a death. The patient is of Muslim origin. I was amazed. The grief in that family was out of proportion if you think about it in Western way of thinking. So you really have to be very careful and tell them, do you want to call your mullah? Do you want to call your village senior? What can I do for you? There is no such course in the medical school which teaches you those things.
For us in the Inland Empire, where I'm from San Bernardino, UCR, the new medical school which is coming on, we're insisting on training culturally competent people.
The ideal is a doctor and a patient from the same culture, understanding the same language, understanding the same values.
Southeast Asian women, they're somewhat uncomfortable with male doctors, and especially if they're not one of them. When my mom visited here, we had to find a physician she was comfortable with.
Workforce diversity, it really has a lot to do with encouraging people with those language skills, with those cultural beliefs into medical school training.
Since so many in this room want to go into healthcare, the next 4, 5, 6 years in your career should be devoted to finding that niche. Which one of these things is going to work for me?
How do you see a tumor?
I always thought that you had to be either a Caucasian male or an Asian to be a doctor. And when I came into this program, it was just a big blend of us.
Once this program was over, I knew exactly what I wanted to be. I planned on being an oncologist.
Going forward, I think what we would like to accomplish around the issues of interpreter services and cultural proficiency is an ability to insinuate these issues into everything that physicians do.
You mentioned that there was a Senate bill to cover language interpretation services.
The Medical Leadership Council has provided a forum for physicians and other medical leaders who really care about this issue.
It brings together a variety of people, people from the public hospitals, people from regular hospitals, doctors, and the community leaders.
We have a coordinated plan. We leverage our resources. We only duplicate best practices. We are learning a lot about what other people are doing and how best to avoid those mistakes. And so you're much better off trying to solve this problem in a coalition type of approach than if you are a single ship out there.
The California Academy of Family Physicians has developed 2 curricula, one on addressing language access in the physician's office and one on assessing your office for how appropriate it is for cultural proficiency and language access. We've also developed 2 DVDs.
What's really powerful about a lot of the projects you see coming out of the Medical Leadership Council are that they're local responses to local problems that have staying power.
So it was an open invitation to about 500 medical staff. We wanted to give them tools that they would have to go back to their offices and be able to implement.
The Medical Leadership Council has been an incredible resource to me.
It has far outstripped our expectations.
It can't be done overnight, but we are proceeding along one step at a time. We'll get there.